Hi, good afternoon, good evening. My name is Hillary Vaughn. I'm a second-year internal medicine resident at Brandon Regional Hospital. We're just outside of Tampa. And this is a case report on COVID-19 infection in a patient who had chronic lymphocytic leukemia. We all know if you've been on COVID floors at this point, what are the risk factors for COVID? It's elderly population, younger people with, obesity, type 2 diabetes, hypertension, etc. I think cancer kind of intuitively is a risk factor. You think about people being on chemo and being immunocompromised. But what I didn't know is that hematologic malignancies actually confer the highest risk in COVID-19 infection. And that's something I learned about with this patient. This patient had CLL, so that's the most common hematologic malignancy. And it has a pretty benign course. It's the old man's disease. You die with CLL, not from CLL. And there's some immunocompromise, but it's a watch and wait type thing. So what I didn't know is that the mortality rate of patients who have the diagnosis of CLL is really high in COVID-19 infection. So this case kind of surprised me. So it's a 64-year-old guy. He had a 10-year history of CLL, and he was admitted to the ICU, right after he presented, maxed out on high flow. He'd been diagnosed with COVID as an outpatient 2 days earlier, just rapid decompensation, received multiple rounds of empiric antibiotics, extended courses of dexamethasone and remdesivir, DVT prophylaxis. He got a small right lower lobe PE sometime on day 12. At that point, we were concerned about bacterial superinfection, reactivation of TV, all of those things kind of came out negative. And then, I started reading case reports, and there's one case report maybe says extra convalescent plasma, so we gave that. And hematology got on board and started IVIG. And then right around hospital day 24, the patient was able to step down on the unit, but still requiring significant amounts of oxygen. He's actually still in the hospital when I'm recording this. And, just a very slow wean on this particular individual. But he's in good spirits, so good for him. In the middle here, I have kind of a discussion. So hematologic malignancy, highest mortality rate, 33%. That's above lung cancer. So active lung cancer has a mortality rate of 28%, and then, kind of down the list. So overall, sure, cancer patients are going to have higher risk, they're immunocompromised, but CLL is just kind of, the dark horse here. So the study that I read is really interesting. What it found is that it doesn't matter where the patients are in their disease course with CLL, whether they've been recently diagnosed or they're later in the disease, whether they're on a tyrosine kinase inhibitor or not, because these patients, you do the watch and wait thing. You don't start the tyrosine kinase inhibitor until, there's reason to, like their white count is too high or they have immunocompromise. So it doesn't matter, just the diagnosis of CLL, regardless of where they are in the disease, has a 33% mortality rate. So the limitation of some of the studies that they were done earlier in the pandemic, maybe, when steroids weren't being used as widely, but I still think it's significant. And the study, recognized the fact that there's selection bias, right? CLL is a disease that affects old men, and old men are more prone to having severe COVID-19 infection. But they still found that the mortality rate was significant. So the other thing I wanted to bring up is that there's no specific guideline when it comes to treating COVID-19 patients with CLL. I think you can expect a prolonged disease course, high risk of mortality, decompensation, ICU admission, requiring intubation. The only thing that I've seen in the literature is maybe hold the tyrosine kinase inhibitors. I don't think that's, based on any evidence, just kind of generally what's done. So the reason I chose this case is because I think it's really important to recognize people who are at high risk of decompensation. And this is one of those subgroups of patients that are at risk. And then the other thing I wanted to point out is that I don't have any evidence really in literature, besides one case report, that extra doses of convalescent plasma or the IVIG work. But the patient reported symptomatically that he felt better after we started these things, and he's survived. So that's kind of it. Thank you.